Good day. I am Hannah de Guzman, a glaucoma specialist. I would like to begin by thanking the Philippine Academy of Ophthalmology and the Philippine Glaucoma Society for the privilege of speaking during this glaucoma session of the annual meeting of the PA. We need to start with a quick update, especially for those who did their training in the previous century. This is very important for understanding the rest of this talk. This classification of angle closure disease was first proposed in 2002 by the ISGEO and has been adopted by both researchers and clinicians. It classifies angle closure according to its stage in the progression, from a narrow angle to glaucomatous optic neuropathy. A primary angle closure suspect, or PACS, has a narrow angle with part of the TM not visible on initial gonioscopy. Once peripheral anterior synechiae or IOP elevation develops, then it becomes primary angle closure, or PAC. When the duration or severity of IOP elevation is sufficient to cause optic nerve head damage, then that is now primary angle closure glaucoma, or PACG or PACG. This is why the old nomenclature using terms like subacute, intermittent, and chronic is hardly being used now. So remember, PACS becomes PAC once there is synechia or high pressure, but it doesn't become glaucoma until the optic nerve develops damage. For this talk, I will be discussing the ZAP trial and the EAGLE study. The ZAP trial compared eyes that underwent laser iridotomy versus no treatment, thus making the acronym of ZAP doubly appropriate. The main paper of the ZAP trial was published in The Lancet in 2019. That alone tells us that it's a very important study because it's an ophthalmology paper that was accepted by a general medicine journal that has an impact factor that's 20 times higher than the highest impact ophthalmology journal. In primary angle closure disease, there are only a few definite indications for laser iridotomy, PACG and PAC, and acute primary angle closure. But what about PACS? Should we be doing laser on all of those eyes? We did not used to have good evidence to guide us. This is what the ZAP trial set out to determine. It was a single center RCT in Zhongshan Ophthalmic Center in Guangzhou, China. It was authored by and guided by many highly experienced international researchers from many developed countries. They recruited 50 to 70-year-olds with PACS. The definition of PACS that they used was 180 degrees or 6 clock hours of the TM not visible on regular or dynamic gonioscopy. This is a broader definition than the usual 270 degrees used by other researchers. So far, there are 10 papers from the ZAP trial, and like many major studies, they published their methodology in a separate paper. I won't be discussing these 8 papers, but I do recommend looking some of them up, especially the papers on the various effects of laser iridotomy. The 2 ZAP trial papers with the greatest implications for clinical decision-making are the primary paper, which was published in The Lancet, and this other paper, which I will be discussing briefly. So in the ZAP trial, they screened a massive number of volunteers from the community to identify primary angle closure suspects. Remember, PACS means no PAS, no elevated IOP, and no optic neuropathy. The eyes that were randomized to treatment underwent pure YAG iridotomy with no adjunctive iridoplasty, and the other eye served as control. They were then followed up for up to 6 years. Initially, the plan was for 3 years, but the study had to be extended in order to recruit more patients and to lengthen the follow-up period. You'll see why soon. The usual examinations were done at every follow-up visit, but take note here, they included a dilated exam at every visit. The primary outcome was progression from PACS to PAC, whether that PAC was due to an elevation of IOP, development of PAS, or due to having an acute primary angle closure episode, or APAC. It was not feasible to include development of glaucomatous optic nerve damage as an endpoint, because that would have meant an extremely long follow-up and an even larger sample size. These are the numbers of events for each endpoint. Take note that the numbers may not add up because some eyes develop more than one endpoint. But the total is 36 eyes in the control group versus 19 eyes in the treatment group. To account for the fact that the events occurred at different time points over the course of 6 years, they computed the results as events per number of eye years. Regardless of how the data are presented, this is a lot less than what was expected, which is why they needed to extend the study, as I mentioned earlier. If these results seem unbelievable to you, we need to consider that we ophthalmologists have a biased viewpoint. Basically, we are only seeing these patients in our clinics and emergency departments, but we are not seeing the other 800 plus narrow angle patients who were fine for up to 6 years. So that's why it might feel like these events are too few for us. So the best way for us to see the big picture is through a trial like this, which is why the ZAP trial is so important and why we are talking about it in this glaucoma session. It's important to note that the majority of events for both groups was PAS, which is a relatively benign condition that does not always lead to long-term consequences, especially if it's prevented from progressing. The number of acute angle closure attacks or acute primary angle closure episodes was also surprisingly low, and most of them occurred after provocative testing, in other words, dilation. It was computed as 6.3 attacks of APAC per 10,000 dilations in the control eyes. And only 2 of the episodes occurred spontaneously, which was computed as 4.4 episodes per 10,000 eye years. The computations based on evidence-based medicine principles resulted in a number needed to treat of 44. That means that if we treat all PACS eyes, we will be unnecessarily treating 43 eyes for every 1 eye that we save from PAC. But remember that saving an eye from progressing to PAC mainly means saving that eye from developing some PAS. Since not all eyes with PAS are going to progress to glaucoma, the actual number needed to treat to prevent 1 case of vision loss from glaucoma is 126. These are extremely high number NNT numbers. As a reference point, the number needed to treat to prevent glaucoma progression in the early manifest glaucoma trial was 6. And the number needed to treat to prevent mortality in diabetes is in the teens. What that means is that we now have good evidence telling us that it's not rational use of health resources to perform iridotomy for every PACS eye. And it revealed a knowledge gap. We now know that we need to find a way to identify those PACS eyes that are at highest risk of progression because they are the ones that will benefit the most from laser iridotomy. But how do we identify high-risk PACS? A few answers can be found in one of the follow-up papers of the ZAP, which was published just a few months ago. This study analyzed the control eyes, or the untreated eyes from the ZAP trial, and compared various ocular biometric parameters of eyes that did not progress with those that did progress. Upon recruitment, the patients underwent a single horizontal scan using the Visante anterior segment OCT. Eyes that were recruited later got an additional vertical scan also. They then compared between the 2 groups the various biometric parameters measured by the ASOCT as well as axial length and lens thickness taken by A-scan. These are the OCT parameters that were measured. Unfortunately, we don't have the time for me to explain what each one is. So I will only explain or describe the 2 parameters that were found to be significant. AOD 500 is the angle opening distance 500 microns away from the scleral spur. A 500 micron line is drawn starting from the scleral spur anteriorly along the edge of the angle. The end of that line marks the point at which the distance from the TM to the iris surface is measured. So this red line is the AOD 500. The iris curvature, on the other hand, is measured by drawing a line from the peripheral extent of the posterior pigmented epithelium of the iris to the most central part at the pupil. The widest measurement from the posterior pigmented epithelium to that line is the iris curvature measurement. They found that every 10 micron decrease in AOD 500 means a 10% higher risk of progressing to PAC. Surprisingly, having a flatter iris curvature was found to be a risk factor rather than a more convex iris curvature. This is explained as possibly being due to the presence of non-pupil block mechanisms or due to eyes with initially flatter irides having greater potential for worsening of their pupil block. Not surprisingly, they found that older age is a risk factor, with older age likely being a surrogate for various biometric parameters like AC depth, lens vault, or lens thickness. As with any disease, when multiple risk factors are present, the odds of disease progression or development increase exponentially. What did we learn from this additional paper of the ZAP trial? Some ocular biometric parameters are better predictors of the risk of developing angle closure or acute angle closure glaucoma. But the knowledge on this is still inadequate, probably because the method of measurement is inadequate. Remember that the ASOCT parameters in this study were measured with single line scans in 1 or 2 axes out of an entire 360 degrees. There can be significant sectoral variations over 360 degrees of angle that would not be captured in just 1 or 2 linear scans. In the future, we may have better results from anterior segment imaging machines if they acquire volumetric data or if they apply artificial intelligence to the imaging data. So we still have to wait for that. In this study, ocular biometric measurements were found to be better predictors than gonioscopy grading. But, and I cannot emphasize this enough, we still need to do gonioscopy. Remember that this is a population of primary angle closure patients and that what we are talking about is trying to further narrow down those who need iridotomy the most. So gonioscopy is still the first step in identifying who has PACS. These are the objective implications of the 2 studies. I've already discussed all of them previously. What I want to remind everyone about now is the caveat that this trial was done in a purely Chinese population. So we can't be sure how well it applies to most of our patients, unless we were to do our own version of the ZAP trial in a Filipino population. The previous slide was the objective implications, but here are the subjective or the more practical implications for practice. How do we advise the PAC suspect that we will see in our clinic tomorrow or next week? Which ones should we offer prophylactic laser to? Firstly, we can say this to most PAC patients. You have a very low risk of developing an attack of acute primary angle closure. So we can simply observe you by doing gonioscopy at every visit. Maybe we can even add a provocative test like dilation. If it's available, and the patient can afford it, then doing serial ASOCTs is an option. Although personally, I will wait for more data and improved technology before I start doing that. If my patient is a PAC suspect, PACS, and they fall under one of these criteria, then I will offer prophylactic laser. Now let's move on to the EAGLE study. The acronym is jumbled in the title of the primary paper. So if we want the EAGLE acronym to make sense, we have to arrange it as Effectiveness for Angle Closure Glaucoma of Lens Extraction. Just like the ZAP trial, it was important enough to be published in the Lancet with some of the same experienced researchers who were part of the ZAP trial. I will not be spending as much time on this study since I think more people are familiar with it because it was published earlier than the ZAP trial. We know that laser iridotomy safely and effectively widens the angle, which is why it's the standard of care for angle closure disease. But we also know that cataract extraction has a wonderful bonus effect of widening the angle. Knowing that, should we be doing lens extraction instead of laser for our angle closure eyes? That's what the EAGLE study tried to find out. It was a multi-center RCT with majority of the centers in the UK. They recruited people aged 50 and older with newly diagnosed PAC or PACG. Those with PAC had to have an IOP of 30 millimeters mercury or more, while those with PACG had to have an elevated IOP. They had to be phakic with no symptomatic cataract. By the way, I'll be remarking on the use of this wording later. Just like other major studies, there are multiple papers and the protocol was published separately. I will only be discussing the primary paper and not the 4 other papers. After screening 805 people, they were able to enroll 419 and randomize them into the standard of care group treated with laser iridotomy initially, and the treatment or experimental group treated with lens extraction. The subjects were followed up for up to 3 years, and aside from the usual glaucoma evaluations during follow-ups, they were also asked to answer 3 different quality of life questionnaires. They were treated within 60 days of randomization. Target IOP varied depending on the individual patient's condition, and additional treatments or interventions were allowed if needed. Lens extraction in the laser group was allowed only if they developed visually significant cataracts or if they needed lens removal to improve their IOP control. The primary outcomes were IOP, quality of life, and cost effectiveness of the treatment. I will not be discussing the cost effectiveness aspect because the study was conducted in a healthcare setting that is very different from ours. Just suffice it to say that they found lens extraction to be cost effective in their healthcare setting. These are the baseline characteristics of the study subjects. As with other well-randomized studies, the results are very similar for the 2 groups, so I won't be discussing each item. However, I very much would like to point out that the median age of the subjects was 67 years old, with an interquartile range of 61 to 73 years, which, by the way, is well within the cataract age group. So the population they were able to enroll turned out to be a lot older than their lowest age cutoff. For completeness sake, here are the rest of the baseline characteristics. These are the results at 36 months. The heading of this column is a little confusing to read. It's the change between baseline and 3 years for each group that is then compared between the 2 groups. The statistically significant results were in 2 of the quality of life questionnaires and in the number of medications. 61% of the laser group was on medication at 36 months with an average of 1.3 topical medications, while 21% of the phaco group needed medication using an average of 0.4 topical medications. The authors attributed the better quality of life scores in the phaco group to lesser need for medication, lesser need for further surgery, correction of refractive error, and elimination of, and I quote, mild age-related changes in lens transparency. More about that quote later. The IOP was slightly lower in the phaco group, but it was not statistically significant. The degree of angle closure, visual acuity, and visual field results were similar between the 2 groups at 36 months. The other statistically significant difference between the 2 groups was the number of additional glaucoma procedures that were needed. It was 24 in the laser group and 1 in the phaco group. The 16 phacos here were performed for IOP purposes and not visual purposes. Refractive error was expectedly lower in the phaco. The variety and number of complications were what would be expected after phaco and LI in angle closure eyes with shallow chambers. While the number was larger in the laser group, many were minor and expected, like bleeding and IOP spikes. The phaco complications included the usual things like including vitreous loss and dislocated IOL. How do we apply the results of the EAGLE study to our practice? The EAGLE study has reinforced that we should have a lower threshold for lens extraction in angle closure eyes. I say reinforced because we've already been doing it. If I have an angle closure patient and an open angle glaucoma patient who both have cataracts of the same density, I will definitely have offered earlier cataract extraction much earlier to the angle closure patient. And I'm sure many of us have already been doing the same thing, even before the results of the EAGLE study came out. But now, because of the EAGLE study, we have good validation for that clinical decision-making of ours. The trickier question is the applicability in the earlier stages of cataract or where there is no cataract at all. for the risks of lens surgery to be justified, a patient with PACS should have a high IOP, like the study population, and the study can't be used to justify doing lens extraction on the disease stages that were not included, like PACS or severe glaucoma. If you'll allow me to digress a little bit here, I just want to state that it's my opinion that at least some or even a majority of the study population already had early cataracts because the subjects were well within the cataract age range, because of the way they defined the inclusion and exclusion criteria, and because of the oddly specific wording used in the discussion on the possible reasons for better quality of life in the phaco group. The reason I wanted to point this out is because I don't want this study to be incorrectly interpreted and used as justification for performing unnecessary cataract surgeries in people with clear lenses. The bottom line of the ZAP trial is that we should target only the highest risk PACS eyes for laser iridotomy to avoid performing too many unnecessary lasers. While the bottom line of the EAGLE study is that doing lens extraction earlier in PAC and PACG eyes has definite benefits that may outweigh the risks of surgery. I hope that this talk has given everyone a lot to think about so that we can make better decisions for our primary angle closure patients. Thank you for listening, and happy anniversary to the Philippine Glaucoma Society.